Guiding a vulnerable patient through a life-altering medical decision is the surgeon's primary obligation, preceding the administrative step of signing a consent form. Today, you are counseling a 52-year-old patient named Sarah, who has recently received a diagnosis of early-stage breast cancer. Before the consultation, you review her pathology, clinical staging T1, N0, M0, with an estrogen receptor positive and HER2 negative receptor status. The multidisciplinary team recommends upfront surgery. To Sarah, these metrics are effectively a foreign language. Success today depends on translating these clinical findings into a clear, actionable narrative to satisfy the requirements for informed consent. Start by sitting down, making direct eye contact, and explicitly confirming the biopsy results. She has breast cancer. Explain that a multidisciplinary team, including radiologists, pathologists, and oncologists, has already reviewed her specific imaging and pathology to design her care plan. Consider the impact of your phrasing here. Does she hear that you alone made the decision, or that a collective of specialists reached a consensus? Presenting a treatment plan as a team-backed recommendation lowers patient anxiety and increases long-term compliance by removing the weight of a single opinion. Define the staging first. T1, N0, M0 means the tumor is small and remains contained entirely within the breast tissue without spreading to her lymph nodes. Describe her ER-positive status as an advantage. This means the tumor relies on estrogen to grow, allowing you to target any remaining cells with oral medication after surgery. By prioritizing physical concepts over medical shorthand, you ensure the patient genuinely comprehends her condition, meeting the legal standard for a patient who is truly informed. Because the tumor is small relative to the breast, you offer two primary surgical options: breast conservation surgery, or a lumpectomy, and a full mastectomy. Sarah might express a common fear that a lumpectomy is the risky choice, and that removing the whole breast offers a better chance at long-term survival. As her surgeon, you address this outcome bias. How do survival rates of these procedures compare over the long term? The clinical evidence is clear. When breast conservation surgery is followed by radiotherapy, it yields identical long-term survival outcomes to a full mastectomy. Correcting the belief that a mastectomy is safer for survival is a critical medico-legal step in providing an unbiased consultation. Next, explain the sentinel lymph node biopsy. This safety check confirms microscopic cancer cells haven't reached the draining nodes in the armpit. Describe the process. You inject a specialized blue dye that mimics the path cancer cells might take, highlighting the sentinel nodes for removal and testing. You should also discuss reconstructive options. If she leans toward a mastectomy, explain the choice between silicone implants or using her own tissue, and whether the reconstruction happens immediately. Detailing these secondary procedures during the initial consultation prevents surgical surprises and ensures the patient provides comprehensive consent. Be explicit about the commitment required for breast conservation surgery. It is always paired with follow-up radiotherapy to the breast. Mention the long-term hormone therapy, such as tamoxifen. Based on her receptor status, these pills block estrogen and prevent the cancer from returning. Every surgical discussion must include the standard risks: bleeding, infection, and the possibility of a second surgery if the initial margins are not clear of tumor cells. There is one more critical risk specifically associated with removing lymph nodes. Can you identify the chronic condition Sarah must be warned about? You must explain the risk of lymphedema, permanent swelling in the arm. Neglecting to discuss these chronic risks verbally during the consultation can easily invalidate the written consent form if severe complications arise. Finally, verify her understanding. Ask Sarah to summarize the plan and its risks in her own words. Sarah should repeat the sequence: lumpectomy, sentinel node biopsy, followed by radiation and hormone pills, while acknowledging the potential for arm swelling. Only after this verification do you finalize the documentation. You check the boxes for diagnosis, procedure, risks, and adjuvant plan before securing the digital signature. Establishing an active, documented dialogue empowers the patient to make an informed choice while providing the physician with robust legal protection.